Thank you to the chairman and to Senator Bozeman for the discussion this morning over the Air Force breakfast and talking about patient safety and talking about mental health and all the things, treating men and women in the service and after they get out of the service as human beings. This week is National Patient Safety Week. I hear directly from VA employees in Ohio regarding safety concerns. At the VA, no surprise, we should applaud those who have the courage to make sure veterans are receiving care in the safest possible environment, speaking out about it when necessary. I want to take a moment to thank Dr. Cox, who testified last year in the HRM, for his team at VHA for their work to make the electronic health record safer. We know VA's electronic record rollout had led to negative outcomes for Ohioans. As Mr. Scalia talked, you were in Columbus recently. Today, my office was briefed on three individual veterans who died in part because of the Oracle Cerner EHRM's failings. Until the 14 technology fixes outlined in the HRM Sprint report are developed, tested, in place, this should not move forward at any other facility. I think you're hearing that from the chairman, the ranking member, Ms. Murray, and others. My first question is for Dr. Evans and Dr. Elnahal, if you would respond to this. I met with VA employees in Columbus a few months ago, right after you announced the assess and address period to find and fix problems with the HRM product, and after Dr. Elnahal's September visit. Frontline VA employees raised frustrations, the kind of frustrations Ms. Murray spoke about connectivity, system latency, workflows. Clinicians raised pharmacy and patient safety concerns, where they went around the table one after another talking about those. We see the effects on productivity, on worker morale, on veteran satisfaction. In January, specific clinics' productivity were still below go live and access to specific clinics at Chalmers, the Columbus facility. Primary care, rheumatology, neurology remain limited. Since go live, the facility's hired additional staff and employees are working overtime to meet veterans' needs. You know all that. No new system launches perfectly, of course. However, we're almost a year post go live in Columbus. Veteran satisfaction is low, worker morale is low, as indicated by the GA report. So how, Dr. Elnahal and Dr. Evans, how can you recommend moving forward to more complex facilities if the current sites aren't back to go live productivity levels? I mean, you've talked about Cleveland, you've talked about Cincinnati, you've talked about Ann Arbor, you've talked about Seattle. How do you go to more complex facilities when you can't get it right in an ambulatory place like Columbus? In either order. Dr. Evans, you want to start?
Sure. First of all, I was just in Columbus myself last week, and I heard many of those same things. And we need to address those issues. There's just no two ways about it, right? This is, in any system, as you said, there are going to be challenges when we roll out a new system, but it is very, very important for us to be sensitive to the operations on the front lines of care and to be identifying where those challenges are and fixing them. To your question about highly complex sites, like those that you mentioned that have some of what we would refer to as our level 1 medical centers, where there's more complex care delivered. I think the VA recently made a decision to move back. We had been considering moving forward with a go live in Ann Arbor, Michigan. And
this fall, right? This late summer or fall.
That's correct. That's correct.
And you've moved that back.
We have moved back.
As you have Cleveland and Cincinnati.
That's correct.
Okay.
And I think, again, this gets to the core principle that I mentioned earlier, and that is we need to know that we are ready to safely deploy a record that will meet the needs of the organization before we go live at sites, particularly at complex sites, but I would argue that would apply to any site. It doesn't matter whether it's highly complex or not complex.
Okay, Dr. Elnahal.
Yeah, thanks, Senator, for the question. As you remember, it was actually my visit to Columbus where I heard directly from frontline users and I observed their workflows about the concerns they had around veteran care that prompted us to do the assess and address after I had a conversation with the Secretary about what I saw. And the need to restore productivity isn't an end in and of itself. It has everything to do with access to care. And it's also a marker about the degree of workarounds and issues that our clinicians have to go through to work around the system rather than having the system function for their needs. And so I do see, and I agree with everything Dr. Evans said about a site-by-site assessment that considers not only productivity, but everything else we've discussed, patient safety risks, a number of other metrics. But there is a ray of hope in that Walla Walla has just reached pre-deployment productivity recently. They have strategies for their workflows that have been able to achieve that. And so we are learning deeply from that experience. And we plan on having that experience be taught and shared in terms of those best practices, not only for sites going forward like Saginaw, but to sites that already have the system like Columbus.
Well, thank you. And Mr. Chairman, thank you for giving one. Mr. Sealy, I'd like to ask you one question. It's been a year ago, and since the purchase of Cerner, since that time, VA employees have told me a lot of things. IT tickets being closed without communicating that back to clinicians, degradations, outages that affect veterans' clinical care, not properly testing upgrades before they go live, which cause pharmacy shortages. You're aware of this. I'm not, and I just don't see the benefit from your system. Veterans frustrated by delays in their care. The contract's coming up for renewal in May of this year without significant changes to the terms of any contract. Why should we support it? What benefits can I start seeing that you're providing?
Well, I think in the issue of tickets being closed, this was feedback that I heard in Columbus last week, and I would agree with you. It's not where it needs to be, and that's on us to address that. And the issue of system availability, though, I think we've made dramatic strides, and we are now at the 99.9% system uptime SLA that is contracted for. So I believe that some of that data is from older reports, and things have been remedied certainly in recent months. It's been 9 months since we've owned the system and made material changes. As I said, if the core and fundamental aspects of the system were flawed, it wouldn't be powering healthcare for countries like the United Kingdom and others. So there are issues. We're working together with the VA and the VHA, and I think that list of 14 accurately summarizes the things that need to be addressed. 7 of those are already addressed and not yet rolled out. The other 7 are in planning to be rolled out. So I do believe that we with the new leadership and the folks that have leaned in at VA, we have very good understanding of what needs to be fixed clinically to make the system better. I do know that the system does work and can work because it works all over the world. Obviously, this implementation has been particularly problematic. But as far as not testing the system and causing outages, my firm belief is that those days are behind us. I don't see that as a continued issue going forward. It hasn't been.
Senator Tillis.
Thank you.
Thank you, Chair Tester. Thank you all for being here. And Chair Tester, I'm glad that we have a panel instead of 2 panels. We've got all the stakeholders at the